Now, in the second section, we will discuss some other very important topics, which will be like indications for definitive airway management. So, what are some conditions in which we need the definitive management of the airway? Then we will discuss rapid sequence intubation, RSI, and then the neuromuscular blockage, and then blind nasotracheal intubation. So, what are some indications for the definitive airway management? Fundamental reasons for which we perform definitive airway management are inability to maintain or protect the airway. So if the patency of the airway is not establishing, or if the airway lost the patency, or if it cannot protect, then we should do the definitive airway management, because there is inability to maintain and protect the airway. Repositioning maneuvers, chin lift, jaw thrust, airway adjuncts like oropharyngeal airway and nasopharyngeal airway, and intubation required who cannot maintain airway. So, inability to maintain or protect the airway after these procedures like head tilt, chin lift position, jaw thrust, all these manual maneuvers, and then after the oropharyngeal airway and nasopharyngeal airway, if the patency of the airway is not maintained, then we need to do the definitive management of the airway. Failure of ventilation or oxygenation, if with all those methods or the techniques of the oxygen delivery, if we are not able to deliver enough oxygen, if the ventilation failed, then we need to go for the definitive therapy, like intubation required based on clinical findings. Delivery of oxygen and positive pressure ventilation. Arterial blood gases are rarely necessary. So these are the fundamental reasons for the definitive airway management. Potential for deterioration based on patient's clinical presentation. Intubate based on anticipated deterioration. Delaying management leads to airway edema, and also management in those with trauma, head injury, etc. So, if there is potential for the deterioration of the condition, and there is chances that the condition of the patient will get worse, we need to perform the definitive airway management. And once we delay the procedure, this can cause airway edema, and with the edema and swelling, there is more obstruction and more the respiratory obstruction and failure. Patient safety and protection. Agitated patients are the candidates for a prophylactic in the intubation. So it's important that if the patient is agitated, we should perform the prophylactic intubation, and we should not wait for the worsening of the condition. Sedation and intubation only safe way. immobilize and protect the patient. So all these are important. We need to consider patient safety and protection also. If the patient is agitated, we should perform intubation and give sedation to the patient. It immobilize and protect the patient from any further damage. Rapid sequence intubation. What is rapid sequence intubation? Is a series of defined steps intended to allow for rapid oral intubation of patient without interposed bag mask ventilation. So in this rapid sequence intubation, it is a series of steps, different steps which allow for rapid oral intubation. So rapid oral intubation, you can see, is being performed without first performing the bag mask ventilation. So rapid sequence intubation, direct intubation without the interposed bag mask ventilation. Bag mask ventilation may lead to gastric distension. So that's the main reason why the BMV is avoided and direct intubation is performed, because it can cause gastric distension, followed by regurgitation and aspiration, pre-oxygenation, and giving an MBA intubation. So it's important that bag mask ventilation is avoided in rapid sequence intubation, and direct oral intubation is performed quickly. Small pre-oxygenation is done and then the procedure is performed. It avoids the gastric distension of the stomach that can occur with bag mask ventilation. And then once the stomach is dilated or distended, there are chances that patient might regurgitate or aspirate that can cause further complications. The 9 P's of rapid sequence intubation. What are the 9 P's we should be performing for the rapid sequence intubation? The first P is possibility of success. So possibility of success, preparation, pre-oxygenation, pre-treatment, paralysis with induction, positioning and protection, placement, proof, post-intubation management. So all these are the 9 P's of the rapid sequence intubation, and you can see that's the time given during which these P's should be performed. First, the possibility of success. It's very important. We should look for the possibility of success, because if the procedure will be a failure and it's totally waste of time, then we should not go for it. So first and most important, how much is the possibility of success? If there are chances that there is a possibility of success, then the preparation of the patient, and as we mentioned in the previous slide, giving pre-oxygenation, so enough oxygen is available during the procedure, and then any pre-treatment is given. Paralysis with induction, positioning and protection, placement of the tube, proof, and then post-intubation management. So these are all the P's of the rapid sequence intubation, and starting from the possibility of procedure, success of the procedure, preparation of the patient, any pre-oxygenation, pre-treatment, and once the procedure is performed, we look for the proper placement, proof of success, and then the post-intubation management. So all this takes very quick. We have just a time of about 10 minutes in which all that is performed. Next is the Lemon Law. Lemon Law is L stands for look externally, look anything externally, any abnormality externally. Then we have E is evaluate the 3-3-2 rule. 3-3-2 rule is just to look for the positionings, whether we have enough space available. This is for the 3 fingers used, 3, 3, and then 2 fingers to look for the anatomical positioning. Then we have malampathy. That's another, we will discuss this in detail in the next slide. Then we have obstruction of the airway and the neck mobility. So that's the Lemon Law. All these things should be observed. The look externally. Then with 3-3-2 rule, look for the anatomic space available. Then we have malampathy, then the obstruction of the airway and mobility of the neck, whether it's mobile, because as a result of trauma or injury that can cause cervical spine fractures or injury to the neck, we have problem in the neck mobility. Next, malampathy classification. What is malampathy classification? This is the malampathy score. Class 1, complete visualization of the soft palate. Here you can see there is complete observation, visualization of the soft palate, so the mouth can open fully and procedure can be easily performed. Complete visualization of the uvula but not the soft palate. In class 3, we have visualization of only the base of the uvula, you can see. And then soft palate is not visible at all, so maybe not a very good patient for the procedure. So all these are covered in the malampathy score. That's part of the Lemon score. Moans anticipating difficult bag mask ventilation, and what this stands for: M is mask seal, O is for obstruction or obesity, A is for the age, N is for no teeth, and S is for the stiff lungs. So anticipating difficult bag mask ventilation, in this moans we have mask seal, obstruction or obesity. So look for all these features that can be present that may make the bag mask ventilation difficult. Preparation is suction should be tested and available at bedside. That's important. We have oxygen mask and bag mask ventilation device available. Airway equipment should be present. Then we have the pharmacy or drugs available. ME for monitoring equipment should be present. So all these are different preparatory steps that needs to be present at the point where the procedure is performed. Steps of rapid sequence intubation. First, the preparation of the patient. SOAP mean mnemonic summarizes necessary preparatory steps. Then we need pre-oxygenation, direct laryngoscopy, and ETT placement stops oxygen delivery. Detrimental arterial oxygenation desaturation less than 90%. Non-breather oxygen mask deliver 70 to 75% of the oxygen. Pre-treatment. Selected pre-treatment medications given like lidocaine, opioids, etc. Paralysis with induction. Rapid IV administration of induction agents, etomidate, thiopental, and methotrexate. So all these are the preparatory steps for the rapid sequence intubation. Now, some pre-treatment medications that can be used, we have lidocaine. Indications for using the lidocaine if there is increased intracranial pressure and there is RAD, in decreased intracranial response to intubation mitigates bronchospasm in patients with RAD. Adult dose 1.5 milligram per kilogram and pediatric is 1.5 milligram per kilogram. Don't give a high grade dose, don't give in the high grade heart block. Then we have opioids, increased intracranial pressure, ischemic heart disease, aortic dissection are the indications. Then we have mechanism of action. It blunts the sympathetic response to laryngoscopy. 3 to 6 microgram per kilogram, 1 to 3 microgram per kilogram, used with caution in young children. Then we have atropine, which are children less than 1 year, adults receiving in second dose of SCH. Mitigates bradycardia response to SCH, 2 milligram, 0.02 milligram per kilogram, only give prior to first dose of SCH. So all these are the pre-treatment medications, lidocaine, opioids, and atropine. Induction agents are barbiturates, methotrexate, benzodiazepines like midazolam, etomidate, and ketamine. So these are all the induction agents. Induction dose is 3 to 6 milligram per kilogram. So both of these are the adult dosages. The onset of action is less than 30 seconds, and its duration is 5 to 10 minutes. Mostly you can see it's about 13 minutes for benzodiazepine. We don't need very long time of induction because the procedure is very quick, lasts for about 10 minutes, so we should be just 5 to 10 minutes is good enough. Benefits are it increase intracranial pressure if there is decrease intracranial pressure if there is increased, decrease intracranial pressure, short duration. Precautions, it cause decreased blood pressure and laryngospasm, decreased blood pressure and laryngospasm. So all these are the induction agents which are used under different conditions and depending on how much time we need for the induction. Neuromuscular blockade, we have NMBAS neuromuscular blocking agents to paralyze the patient. So, neuromuscular blocking agents are used to paralyze the patient, facilitating rapid endotracheal intubation. Do not provide analgesia and sedation. Succinylcholine, depolarizing neuromuscular blocking agent. Dose of succinylcholine given is 1.5 milligram per kilogram intravenously pushed in adults. And non-depolarizing neuromuscular blocking agent like rocuronium. So all these are the neuromuscular blocking agents like succinylcholine can be used to provide to rapid intubation should be performed without analgesia and sedation. So that's the another method of endotracheal or nasotracheal intubation. Neuromuscular blocking agents like succinylcholine, dose is again 1.5 milligram per kilogram adults, 2 milligram per kilogram children, 45 to 60 seconds, and duration is 6 to 12 minutes. So it's very, very rapid onset and duration is pretty much good. Non-depolarizing agents like rocuronium, vacuronium, and then we have pancuronium, 1 milligram per kilogram, 0.5 milligram per kilogram, 0.1 milligram per kilogram. This is the time for the onset of action, and duration is quite long, 30 to 60 minutes, 60 to 75, and 120 to 155, depending on whether we need that long duration for intubation. We can try non-depolarizing agents. Rapid sequence intubation, what is the positioning of the patient for oral, pharyngeal, and laryngeal airway access? Protection, Salix maneuver maintained until endotracheal tube is placed. Placement is backward, upward, rightward pressure. So backward, upward, rightward pressure maneuver. Proof is the confirmation of endotracheal tube placement by clinical assessment, ET carbon dioxide detection, and pulse oximetry. These are some proof which tell us that the endotracheal tube is functioning properly or not. Post-intubation management is post-intubation X-ray. Other ways of definitive airway management, we have immediate crash intubation, immediate intubation without any medication. Disadvantages, it causes increased intracranial pressure from stress of intubation. Technical ease and immediacy. Awake oral intubation uses liberal topical airway anesthesia, mild IV sedation prior to inspection. Then preservation of patient's airway reflexes. Blind nasotracheal intubation consumes more time, fails more often because it's blind. Used when RSI is not advisable. Contraindicated in the apneic patients who have no breathing. Those with coagulopathy develop epistaxis from blind nasotracheal intubation. So that concludes our section 2. Thank you for watching sqadia.com.